As a board member, I've been so proud to hear about what you've said about working with the company, and 3 themes have elevated. One is the relationship. You really value the relationship with the doctor's company, and that says a lot. The other is the trust that you have because of that relationship. And the third is the innovation that you're invited to engage in as a clinician. The clinician voice is heard. And I thought about that, and I'm thinking about it as it relates to the redesign of primary care. I'm a practicing primary care physician. Are there any other physicians who are practicing in primary care? There we go. And how it is, what we do offer is that relationship and that trust. And that is this secret sauce of our profession. And so I'm going to go through my experiences at Stanford and at UCSF. I was at UCSF before. I spent some time in East Africa looking at primary care, and I'll talk about that as well. These are the 3 different areas that we're going to be talking about. So one is, how did the transformations that resulted from the COVID-19 pandemic, how did that impact and influence primary care? And as I've been thinking about the day, I'm going to take a positive spin, but then also talk about the shortcomings, but a positive spin and how these transformations impacted my ability as a primary care provider and also my colleagues' ability to provide care. We'll also talk about this redesign model that we developed. What are the things that we need to be thinking about in the future of primary care as we think of primary care being at the forefront of this transformation that's happening in healthcare in general. So this is some data that we presented. I represented Stanford Healthcare at the Congress, with the Committee of Ways and Means and the Subcommittee on Health. And we talked about telehealth and CMS reimbursement of those visits during the COVID pandemic and how to extend those public health emergency waivers onward after the immediate crisis. And so you can see at the very start of the chart, before the pandemic hit, we were at about 1% of our total visits were virtual visits. And then April 2020, we had to shift, like everybody did in this room, and we started to provide 70% of our visits were virtual. We've stabilized, obviously, we've reopened our clinics, and there's a lot of in-person visits now, but here we are in the middle of Silicon Valley, where there's a relatively high adoption of technology among our patients, and primary care has stabilized at around 50%, 40-50%, whereas psychiatry is almost entirely virtual at this time, 96%. And just as a point of reference, in case you're interested, neurology is, of all the specialties, has the lowest adoption of telehealth at this point, but still pretty good at 30 to 40%. I know nationally it's around 20% or less, and so these are relatively high numbers. Lots of benefits for our patients. Maybe we need to rethink how it's impacting the provider and the care team, and we have to start thinking about the model. So one more data point before I start talking about the redesign model, and that is what we've talked about today as well, the shortages of primary care physicians. And really, if you look at the growth, and this is data coming, it's a model that AAMC put together, it's not growing all that much, maybe 5% over the next 10 years, whereas you can see for every new physician who's entering the primary care workforce, there will be 2 advanced practice clinicians who are entering the workforce. So thank goodness, help is on the way, and we're benefiting from that. And my perspective is the more the merrier. So we all need to chip in to help with this problem. You can see the projections here of the shortages of primary care physicians and the impact that will have on the workforce. So we need to work in teams. There's no question in primary care. There are not enough physicians. And so this is the model that, so primary care 2.0 model. I'm gonna spend some time on this. There are 3 care teams, and in each care team, there is an MD and an APC working together, and they're supported by 4 medical assistants. The medical assistants do prescribe provide in-room scribing function so that documentation is taken care of. We can talk about the wellness component of that because we've had this model now for a long time. But that was the model. And those 3 core care teams that were managing 3,333 patients in their panel, they were supported by an extended care team. And these are the members. We had in the model not 1, but 2 behavioral health specialists, a pharmacist, a case manager who is a nurse, the manager, the assistant clinic manager. We also had a nutritionist and physical therapy. There was some co-location with specialists in these clinics so that there was a seamless communication. And the structures that supported this model, I wanted to just point out and spend some time on. So it was really important for us to understand the roles, who was doing what. And so spending some time with role definition is some advice that we learned was really important for us to perform in this model. The other was authorization protocols. Those are incredible because if you can determine what, let's say, a pharmacist can do to manage chronic diseases, hypertension, diabetes on their own. So I rarely see a hypertensive patient and do the management of their medications. That is taken care of by a pharmacist entirely. Same thing with diabetes. Unfortunately, with all the new diabetes medications, I'm very happy that I have a pharmacist who is managing that for me, and they see the patient. Another important part of that is the trust transfer. I was talking about trust a little bit earlier, and how, as a physician, we have a long-term trusting relationship with our patients. We have to transfer that trust, if we really feel it, it will come through to the patient that I might not see you next time. It will be a member of my team, and I know that they're going to take care of you. And they always communicate to me. And that was a helpful part of the model. Tech-enabled workflows, we're going to talk about a little bit. The emphasis on population health and having effective population health navigators. And then the newer development that has happened since the pandemic is the uptake of e-consult. This is a way to message a colleague and ask them how they would manage or at least initiate the workup of an undiagnosed condition or actually a diagnosed condition. Any specialist across our system is able to respond, and 40% of the issues are resolved. So that in that way, it's giving, from the perspective of the patient, the provider superpower, the primary care provider superpowers. We have the ability to provide specialty level care, but through the primary care platform, which obviously has its efficiencies and cost effectiveness related to it. 30% of our primary care patients will be receiving care from non-traditional providers, and I know we have a representative from Village MD being one of those. But this is a pretty exciting time, and the most compelling part of this for me when I look at what the future is going to look like is, well, first of all, help is on the way, that perhaps there will be some innovations that are happening outside of academia, outside of traditional models, that will help us move towards more value-based care and more aligned with what primary care ultimately should look like. I'm very excited about that. The other is that we still have a large portion of traditional fee-for-service that will persist. And so just being aware of that it was just going to be a much more heterogeneous group of models. And perhaps that means that we will have more models for the right model for the right provider, the right model for the right patient. Thinking about risk stratification, which patient should go to some of these models is something that we can think about. And then the last is, I wanted to point out, is that there will be, I predict, a coordination challenge, because as much as we can build an interoperability, I am concerned about a patient who does go from one system to another system, and what will happen as far as navigation and care coordination, and will that fall on the backs of the primary care provider who's already overwhelmed, as we talked about. And so from a wellness perspective, I'm concerned about that. But it's interesting to see what's to come for sure. So the ultimate goal is moving from reactive to proactive, episodic to continuous, one box fits all to personalized care, including patient preferences if they want virtual care, if they want in-person care, for example. And then, of course, becoming much more patient-centric, but actually, let's say, more consumer focused. And at Stanford, this is sort of the model that we've been thinking about as we start to re-stratify and resource adjust our panels so that we can provide the right team composition and the right interventions based on the person in front of us. And we don't have the analytic power that a lot of these tech-enabled value-based care programs have, like Concerto Care, like so many others, Aurora Health, Oak Street, CareMore, et cetera. But I do like this idea of what are these partnerships going to look like for us in the future, and how can everyone benefit from what's happening in the innovation space. I'll end by talking about the perspective of the primary care physician. A lot of times we do describe our work like being a hamster on the wheel. What the future looks like, it has and actually current state at many clinics, much more heterogeneity during the day, a lot more variety. We're working in teams. We are using the data to craft the intervention, and then just so much more virtual care. Time for quality improvement and in-basket management. I'll end, this is my last slide, to just also reflect, and we've been talking about this earlier. I've been hearing Andy talk about this quite a bit, and that is thinking about all patients, thinking about Ruby, thinking about all patients when we are designing these new models, and the importance, if we're going to be successful in the health equity realm, the importance of thinking about diversity in teams. Who in the team could perhaps connect culturally or have some chemistry with our patients so that they can feel like they have a powerful relationship, a trusting relationship with their care team. And that, I think, is going to become increasingly important as we go forward. So with that, I'll end, and I know we're going to have a general Q&A after this, but I do want to just appreciate everyone's leaning in to the transformation ahead of us and your commitment to patient care. Thank you.